Welcome, Thomas, and I'll hand it over to you.
Thank you. Thank you for having me. Good afternoon, ladies and gentlemen. Hi, everyone at home, if you're watching. I would like to give you some food for thought about the impact of lithium on the brain. This is one of the chapters in the neurodegenerative wars, which I call Lithium Strikes Back. I do not have any conflict of interest or interest in conflict. And since I'm talking about lithium, it would be difficult to get a conflict of interest even I wanted to. Now, I am interested in the brain, and not only is the brain Woody Allen's second most favorite organ, it is also the most complicated matter in the known universe. Now, if the brain was so simple that we could understand it, we would be so simple that we could not. So while we may never be able to sort of breach this philosophical boundary, the hope was that with the use of brain imaging and some of the novel technologies, we'll be able to get really, really close to it. And we certainly have learned a lot about the brain using these techniques. But as a clinician, I am willing to admit that brain imaging has overpromised and underperformed. Unfortunately, brain imaging is of very little use in everyday practice of clinical psychiatry. And I would posit that the main reason why brain imaging has not informed clinical psychiatry is related to the fact that clinical psychiatry has not informed the brain imaging research sufficiently. And what I'm talking about is the heterogeneity, the marked differences between patients, which is obvious to every clinician, but which tends to be ignored in these brain imaging studies. And until we correctly name the phenomena, until we have more details about the phenomena that we're observing, we will be making false conclusions. So it is quite obvious that patients with the same diagnosis markedly differ, not only in their clinical symptoms, but also in their comorbidities, in their illness scores, in their response to medications, in the impact of illness on their cognitive functioning, impact of illness on their psychosocial functioning. It's also no surprise that there's marked heterogeneity in finding in the brain imaging literature, which also shows marked differences between studies of the same patients and between the patients with the same diagnosis. And those two phenomena, the clinical and neurobiological heterogeneity, are likely closely linked. And yet, most studies still look for that mythical common average patient with bipolar disorder, yet nobody knows what that patient really looks like, instead of actually trying to identify what are the reasons for the differences across the patients. And while in life it is perhaps not the best idea to focus on the differences rather than on the commonalities, in research it's a really good research agenda to focus just on that. So why is it that some people with bipolar disorders or schizophrenia show marked brain alterations, whereas others with the same diagnosis show no such changes? And once this idea kind of clicks in your brain, it is hard to unsee it, same as this bistable percept. You will no longer be impressed by studies showing on average patients with disorder had this amount of hippocampal volume and those other ones had that amount. That no longer comes as so interesting when you realize, well, it's likely big differences between the patients and what is driving those. So when there are differences within the same diagnosis, it clearly means that there's got to be some extra diagnostic factors at play. And just to show you what the heterogeneity, how big a problem it can be. So for example, here we have some meta-analysis, which presumably are the pinnacle of the evidence base. And there's about 5 or 6 meta-analyses showing that in unipolar depression, hippocampal volumes are smaller in patients than in controls. Now, there's about 7 meta-analysis in bipolar disorders, or saying that actually hippocampal volumes in bipolar patients are comparable to controls. Now that makes no sense, because there is a marked, there's nothing in unipolar depression that would not be in bipolar disorders. And in addition, people with bipolar disorders also have manias, which cannot be good for the brain. Furthermore, bipolar disorder is the more recurrent, starts earlier. So why would that not show a biological change that we see in depression? And people have tried to wrap their head around it with somewhat tortuous explanations. But I think it's more likely related to the differences in the treatments, specifically in people using lithium more to treat bipolar disorders than unipolar depression. So that finally brings us to the topic of this presentation. And lithium is rather interesting. It's been around since a few minutes after the Big Bang. It was reintroduced to psychiatry in 1949 by John Cade. Since then, it has gained and maintained a gold standard for mood stabilization, anti-manic, antidepressant, anti-suicidal, anti-aggressive, as well as antipsychotic properties. Now, it's striking that after all this time, we're still discovering new properties of lithium, and the effects of lithium are quite impressive, and many people have commented on that, including poets and artists. So it's really quite extraordinary that after all this time, we're still getting impressed and surprised by some novel properties that lithium has. And one that I find particularly interesting are the neuroprotective effects, where in animal cultures or in tissue cultures or animal models, if you pretreat neurons with lithium, you will protect them from essentially any noxious or toxic stimulus, be it ischemia, hypoglycemia, infection, inflammation, amyloid, various neurotoxins. Neurons on lithium are more resilient to all these things than neurons that are not exposed to lithium. Now, the question is whether something like that exists in human subjects, and whether the absence of hippocampal volume changes in bipolar disorders was related to this hypothesis that it has to do with the treatment, not with any features of the illness itself. And to look into that, we performed a meta-analysis where we, unlike all the other studies, we just lumped patients based on the diagnosis. We actually subdivided it based on exposure to medications. So we had studies which only contained people who were treated with lithium. We had studies that only had patients who were not on lithium, and we had studies that had both, and compared those to subgroups. And when we looked at the results, as expected, we found that people who were not on lithium with bipolar disorders actually had smaller hippocampal volumes than control. So it's very much in keeping with the findings in unipolar depression. Also, in keeping with our expectations, people who were on lithium had significantly larger hippocampal volumes than controls. Now, if you sum up this negative effect size with this positive, you find no difference. So that's an explanation for why those previous meta-analyses did not find a difference in hippocampal volumes. Now, the fact that people on lithium had larger hippocampal volumes does not immediately mean that this was caused by lithium. And actually, I would not make that conclusion based on those studies, because generally speaking, information about dosage, duration, and compliance was missing in most of these studies, where the kind of level of scrutiny was the patient on lithium at the time of scanning or not? So that really is not enough information to make any conclusions. So to address this issue, we designed within the IGSLi group a series of studies which had, I think, very clever, interesting design. First of all, we wanted to maximize the impact of illness on people's brains, because the idea is that bipolar disorder is, at least some forms of it are neuroprogressive, so that people will accumulate brain changes over time. So if you're looking at someone who's at the early stages of the illness, you may not see anything, so it may not be a good idea to test effects of medications on the brain in someone whose brain is not intact. So it's better to try to maximize that. So we wanted people to have at least 10 years of illness and at least 5 episodes to ensure that there would have been some impact of the illness on the brain already. Now, we also wanted to make sure that people on lithium had a sufficient and documented exposure to lithium. And that's the big advantage of the IGSLi collaboration, working with the lithium clinics, where we could actually select a group of people who had at least 2 years of ongoing, regularly monitored lithium treatment with regular documentation of their compliance throughout all that time. Now, in the non-lithium group, we wanted to make sure that these people did not have a previous exposure to lithium, because obviously it's not the neuroprotective effects is not something that disappears the moment you stop the medications. It's probably something that persists beyond that. So in the non-lithium group, we wanted to find people who had less than 3 months of lifetime lithium exposure more than 2 years ago. And this was actually the more difficult group to find and recruit. Now, exactly in keeping with our expectations, what we found was that the people who were treated with lithium had comparable hippocampal volumes to controls, despite the fact that these people had a substantial illness burden, average of 8 episodes and more than 25 years of illness on average. Now, the people on lithium had significantly larger hippocampal volumes than people who were not on lithium, despite the fact that these two clinical groups were comparable in all the other measures of illness burden. So it was not confounded by a smaller illness burden in the lithium group. They were quite comparable. Now, we found the same pattern of changes when we used a very different method of data analysis, when we used this automated voxel-based morphometry, which is completely independent of any operator biases. And we found the same pattern of changes when we looked at a different type of brain imaging measures. Specifically, we used magnetic resonance spectroscopy and looked at the levels of N-acetyl aspartate, which is a marker of neuronal health, which we measured in the frontal lobe. And we saw the same thing, that the controls and lithium-treated patients were comparable, and the lithium-treated patients had significantly greater concentrations of N-acetyl aspartate than the non-lithium group. Now, what was also incredible was the consistency, not only between the methods, but across the sites, where in each modality and in each site, it was the same pattern, with the non-lithium people being the worst off and the lithium and controls being comparable. Furthermore, what we saw was that the people who were not treated with lithium showed a age association with changes in N-acetyl aspartate, which was not seen in the people who were exposed to lithium. We also wanted to make sure that these are, to test whether these are actually just regional changes in the hippocampus or in the frontal lobe, or whether it's a more widespread pattern. And to query that, we used a sort of machine learning, artificial intelligence-based multivariate method named brain age, where we actually taught a computer model to estimate the age of a brain, and then we applied that model to our patients' data. So for each patient, we got the estimated age of their brain, and we compared it to their chronological age. And kind of intuitively, you feel that if your brain is much older than you are, that's probably not a great thing. But it doesn't need to be, it's not just a measure of accelerated aging. Actually, it's a measure of any pathology which affects the brain in the same direction as aging, which is really most of them. So you would see you would see greater brain age in all sorts of neurological conditions. So I see it not as a measure of aging, more as a measure of overall brain kind of damage. And so if bipolar disorders are associated with neuroprogression, we expected that we will see advanced brain relative to chronological age in people with bipolar disorders. And if lithium slows this neuroprogression, we would expect there to be comparable brain and chronological age in people who were treated with lithium. And that is exactly what we found. On the left, you see that the chronological age and the brain age were pretty comparable in the lithium participants, whereas in those who were not on lithium, the brain age was significantly higher than the chronological age. And that's again despite the fact that the two patient groups were comparable in their illness burden. And that translated into a higher brain age gap in those non-lithium group and comparable brain age gaps, which are essentially zero in the lithium and control groups. Now, we were also kind of wondering, these were obviously highly selected patients from lithium clinics who had to meet certain stringent inclusion and exclusion criteria. So you may say, well, this does not generalize to an everyday patient. And that would be a fair comment. So to address that problem, we collaborate with the Enigma consortium, through which we were able to gain access to large sample sizes of patients recruited around the world. So we got a very generalizable snapshot of bipolar disorders globally. And for the gray matter, we were able to get data from over 2,500 bipolar patients, 700 of those taking lithium. And for white matter, it was almost 1,500 patients and 800 taking lithium in 13 countries on 6 continents. And again, similar to what we saw in that very controlled study, lithium was significantly associated with greater cortical thickness and with higher fractional anisotropy, which is a measure of integrity of the white matter, whereas antipsychotics or anticonvulsants were associated with lower cortical thickness and lower fractional anisotropy. Now, how do we interpret these findings? So, from studies by us and others, it seems that people who are at the early stages of bipolar disorders or people who are at genetic risk, such as offspring of bipolar parents, their brains are impossible to distinguish from brains of healthy controls. Now, if you look at patients who've been chronically ill, their brains are distinguishable from brains of healthy controls unless they've been treated with lithium. So an obvious conclusion would be, well, this is an effect of lithium, but that's not really the only explanation. So let's explore some alternative explanations to see how confident we are in that conclusion. So it is possible that people who respond to lithium are a separate subgroup within bipolar disorders, are people who may not have a neuroprogressive illness as such. It's also possible that when we're prescribing lithium, we're kind of subconsciously selecting patients who have bigger brains, who may have favorable clinical characteristics, who may be more compliant, may be more able to comply with the monitoring, for example. It may also be that patients who are on lithium have generally fewer episodes and lower illness activity, and that could protect their brains. So all of these reasons could explain why we saw greater integrity of the brain in people on lithium without lithium actually causing that. But it wouldn't have fit our data because actually almost 70% of patients on the lithium continue to experience episodes. So these were not full lithium responders, and all but one of the non-lithium participants were actually lithium naive, so there could have been lithium responders among them. In other words, we were not separating the groups into lithium responders and non-responders. Also, the groups were comparable in all the clinical characteristics that we were able to collect. So that speaks against some of the other patient-related factors acting against this. And last but not least, in the Enigma studies, considering that these were patients recruited around the world using different inclusion-exclusion criteria, different methods of recruitment, we have to ask ourselves, how likely is it that all of these patients were selected for lithium treatment based on the same clinical characteristics, and how likely is it that all of these patients in the study had an excellent lithium response? I think response to both of these questions is that the chance is very low. So most likely the heterogeneity, if that was a factor, would have eliminated findings in this study, and it did not. So the other question is, well, maybe we're not seeing positive effects of lithium, maybe we're actually seeing negative effects of the other medications. And there's certainly a lot of evidence suggesting negative association between, for example, valproate or antipsychotics and brain structure on preclinical, clinical, as well as the MRI level. But again, in our own as well as in the Enigma studies, we did confirm this negative association between antipsychotics or anticonvulsants and brain structure, but the positive effects of lithium persisted even when we controlled for exposure to other medications. Now you can say, well, maybe these are spurious findings from small studies, but there's now 5 mega-analyses in hundreds or thousands of people which have all documented this effect, so it's not a false positive finding. You can say, well, these are cross-sectional studies and association does not mean causation. Well, there is now about 10 longitudinal studies which essentially have all suggested that lithium treatment leads to improvements in brain structure. And this actually includes two randomized controlled trials where people were randomized to lithium. So that again speaks against the prescription biases that I alluded to earlier. So to interpret this, I think we can fairly reasonably discount all of these factors. So based on my favorite philosopher of science, Sherlock Holmes, when you have eliminated all which is impossible, then whatever remains, however improbable, must be the truth. So I think what we're actually seeing are the effects of lithium. And I would say that the evidence based for this is really strong. It was documented in the largest studies, in the best controlled studies, in all the prospective studies, in multiple meta-analysis. So I think it's safe to conclude that we have level 1 evidence for positive effects of lithium on brain structure in human individuals. Now this raises many more questions than it answers. And to me, a key question was whether what we're seeing is really an effect of lithium or is an effect of better control of the bipolar disorder by lithium. So if we're assuming that it's the episodes that cause the brain changes, then if people who are on lithium have fewer episodes, then their brains are going to be more protected. And that may not be a direct effect of lithium. Or it's also possible that this is one benefit of lithium, but that there's a separate one where actually through some additional biochemical pathways, lithium may directly target the pro and anti-apoptotic mechanisms in neurons. Now we looked at this quite carefully, and first of all, in the brain age study, we did not see an association between brain age and treatment response, and we saw positive effect on brain age even in people who were partial lithium responders. In the hippocampal studies, we saw that even people who continued to have episodes on lithium, they still had larger hippocampal volume than the non-lithium group. And there is a study in healthy volunteers where lithium was associated with gray matter increases in people who did not have any episodes to be prevented. So it clearly was not an effect mediated by the illness episode. So all of this seems to suggest that what we are seeing is actually the direct effect of lithium, not an indirect one mediated by the treatment response. Now, this is actually quite interesting, the kind of links between the effects of the medication on the brain and the effects of treatment response to that medication on the brain. So here I've shown you some evidence that obviously lithium prevents relapses, and lithium is associated with improvements in brain structure regardless of the relapses. Now in antipsychotics, it's quite different. We know that the two strongest predictors of brain changes in psychosis are relapses and antipsychotic treatments, despite the fact that antipsychotics are the best available method for preventing relapses. So antipsychotics reduce the effects of the relapses, but they still independently cause negative brain changes. Now, it's somewhat more complicated with antidepressants, where there was also the idea that they may be neuroprotective. The evidence for that is not very strong because all of those meta-analyses that I mentioned to you before actually included patients who were treated with medications, with antidepressants. So in those instances, the antidepressants did not eliminate that effect of the illness, whereas in bipolar disorders, lithium did eliminate that effect of the illness. And there is now some evidence suggesting that yes, antidepressants may be positively associated with improvements in brain structure, but only in people who respond to the antidepressant treatment. So that in the antidepressants is actually the effect of the symptom resolution rather than a direct effect of the antidepressants. Now, again, still more questions. So if we're saying that bipolar disorders is neuroprogressive, does that increase the rates of other neurodegenerative disorders? And if lithium can actually alleviate this neuroprogressive effect, could lithium then help lower the risk of other neurodegenerative disorders in people with bipolar disorders? And if lithium works independent of the mood episodes, could it even lower the risk of neurodegenerative disorders in people who don't have bipolar disorders? And so there is attempts to look at that through population data. And this is something that Dr. Alda worked on in Nova Scotia, where in the Nova Scotia population data, we see that psychiatric patients have much greater risks of Alzheimer's dementia. And that's very much in keeping with other population studies, including mostly from Denmark, where again the bipolar disorder is a risk factor for dementia, and that's even in comparison to other psychiatric disorders and to patients with other chronic disorders, for example. Now, so that's the kind of background of it. On that background, people who are treated with lithium actually do better than the average bipolar patients. They have a lower rate of dementia than bipolar patients who are not treated with lithium. And that's again in keeping with the population data again from Denmark as well as from US, where this is really interesting. Here you see that a single prescription of lithium was associated with increased risk of dementia. That's this confounding by indication that lithium is prescribed for bipolar disorder, which is a strong predictor of dementia. But multiple prescriptions of lithium actually brought that risk back to essentially a population level. It did not go to zero because it cannot go to zero. There's a population background on which these things exist. Contrast that with valproate, where a single prescription of valproate increased the rate and multiple prescriptions increased it even further. And similar conclusions were driven from the Gerhard et al. Study in the US, where people treated with lithium were protected from dementia, people on anticonvulsants were not. But you needed to be on lithium for at least 300 days continuously. Shorter or intermittent treatment would not have been effective in preventing dementia. And these data have even been meta-analyzed, and the conclusion is that the odds ratio for dementia in people treated with lithium is about 0.5. Now, obviously, there's a lot of potential confounders in these population studies, predominantly the prescriber bias, where maybe patients with cognitive impairment may be less likely to be prescribed lithium because people worry about worsening cognition with lithium, or they may be less able to tolerate lithium. So as a consequence, you would see more people with dementia in those who are not treated with lithium and more lithium treatment in people who don't have dementia. So we need a randomized controlled trial to eliminate these potential confounders. And there actually are a few of these trials. Now, I'll start from the bottom here. There was a multi-site trial in Alzheimer's dementia where overall in that study there was no effect, but there was a single side effect on cognition and BDNF. Now, there are two big issues with this study. First of all, it was done already in people with Alzheimer's dementia. At that point, it may be too late to intervene. And second of all, this was essentially only 4 weeks of lithium treatment with, I don't know why they did 6 weeks titration. So 4 weeks of lithium treatment is very unlikely to do anything with already established diagnosis of Alzheimer's dementia. So there's I guess, a study that makes more sense to me in amnestic mild cognitive impairment, so the risk factor, the precursor of Alzheimer's dementia, which use treatment for longer period of time with smaller doses to make it safer, but still to achieve a longer exposure. And this study showed positive effects on cognition, CSF biomarkers, both phosphorylated tau and beta amyloid. So if we summarize the evidence across these different levels, and if we compare lithium to other psychiatric medications that were also considered neuroprotective and of potential use in dementia. So we see that there's quite a lot of evidence in the lithium group. There's actually not much evidence or even evidence for negative effects in case of valproate or antipsychotics. And that includes preclinical studies, replicated neuroimaging evidence, pharmacoepidemiological case control studies, even RCTs for Alzheimer's dementia and mild cognitive impairment. Now, so to me, I would say, well, this is enough of a signal to explore this further. But unfortunately, the Alzheimer's Dementia Collaborative Study, which is one of the main players in this field, said that not without dissent, the decision was to abandon plans to pursue lithium for Alzheimer's dementia because of uncertainty regarding the feasibility of safely achieving sufficient lithium levels in a vulnerable group of patients. Now, I don't know about you, but I'm not buying this for several reasons. We have a recent study with Dr. Forlenza as a part of the GAGE-BD trial in elderly people with bipolar disorders, where actually lithium use was associated with more favorable clinical profile compared with those treated with other drugs. Lithium users at lower levels of depression, better global cognitive and functional state, fewer comorbid psychiatric and cardiovascular disorders, and less antipsychotic use. So the present data do not support the notion that lithium use in older bipolar patients is necessarily associated with unacceptable risks or adverse outcomes. That's the first thing. Second thing is, why would we want to achieve the same levels as we use for treatment of bipolar disorders where we're addressing a different pathology? That just is a leap of faith. I don't think there's any reason to suspect that we need the same doses. And actually, in that study of the amnestic malcognitive impairment, these were usually subtherapeutic levels, as you can see here, 0.25 to 0.5. And there's another study which used microdosing of lithium, 300 micrograms of lithium, which prevented cognitive loss over 15 months. So I think it's more the duration of exposure is more important than the dose, and the dose actually can be quite low. That's further supported by the recent evidence linking the concentrations of lithium in drinking water, which are 100 to 10,000 times lower than the concentrations that we use for treatment, and the dementia. And there's now several studies, including one from Denmark, one from Texas, and one from Japan, where actually variations in the lithium in drinking water in these 100 to 10,000 times lower concentrations still was linked with varying risk of dementia over time. So I don't think this concern has much to do with actual real concern about the dosing or about the need to even achieve the doses as I've shown you. I think the issue is that lithium is not produced in a fancy biotech company in Switzerland. It's actually mined in a very industrial way in, for example, the Atacama Desert here. And so no pharmaceutical company is going to make any money out of lithium. And lithium survived on the basis of evidence, not based on the basis of marketing. There's never going to be any farm representatives going around the offices and saying that you need to prescribe lithium. It's the best thing ever. So I think that's the main reason. Lithium is a natural element and it cannot be patented. So that's the problem. And it is very unfortunate that because of that, the research into this field is actually not very active. I was checking the registry of studies. There is one trial of lithium water for treatment of Alzheimer's patients. And I guess you won't be able to figure out which esteemed university is doing this study because it's the American Society of Thermalism and Climatology. And I'm not making that up. So I was quite happy when recently there was another study pop up in the trial registry, one from Pittsburgh. But when I checked yesterday, it said active, not recruiting. So I don't know whether it means that they finished recruiting or whether it means that they stopped the study, or I don't know what's going on. Now there are fortunately 2 more studies that were just registered very recently this year. This is a lithium-based medication to improve neurological outcomes after surgical carotid reconstruction. This is a Russian study. And there's one study in amyotrophic lateral sclerosis, which was just added in August, actually. So all I'm saying is give lithium a chance. Now, so to conclude, there's a growing body of evidence suggesting that in some patients, bipolar disorders are neuroprogressive, that there's an accumulation of brain changes over time, which likely explains the fact that people with bipolar disorders are at a greater risk of having dementia. There's also an accumulated body of evidence that does not need to happen in people who are treated with lithium, that they may be protected from these effects of the illness and from the increased risk of dementia. So that actually brings forward the idea of prevention in psychiatry, which is something quite unheard of. If people with bipolar disorder start with a fairly pristine brain, then maybe our goal should be to keep it that way. And maybe lithium would be one way of doing that. Now, it's also interesting that the neuroprotective effects of lithium were independent of prophylaxis of mood disorders. So that means that patients who don't have bipolar disorder can still benefit from these effects. And I think it should be further researched in neurodegenerative disorders. And I would very much like to thank all my friends and colleagues around the world, and thank you for your attention.
So, thank you very much for the presentation. There might be a few questions. Yeah.
Yes.
You can start off, Louis.
Hi, I just want to point out to you to another molecule, tamoxifen, that you're familiar with. And there are some studies showing that it helps mania. The India equivalent of the FDA has already approved a metabolite of tamoxifen. It's being marketed and it will be pursued in the US. Interestingly, tamoxifen has two other properties that shares with lithium. One, the prevention of the size of a stroke after in animal models in rats where you block the middle cerebral artery. You look at the brains of the rats without lithium and with lithium, without tamoxifen and with tamoxifen, is striking.
Right.
The second analogy is this recently published study, a cohort analysis of women taking tamoxifen for years for prevention of breast cancer, having a decreased incidence of Alzheimer's disease, Parkinson's disease, and other dementias. Quite striking that tamoxifen is doing that. Other aromatase inhibitors don't do it. So might be some common mechanism between tamoxifen and lithium and not the aromatase inhibition properties of tamoxifen.
Could this be used in males as well?
Well, the studies on mania include males, absolutely.
Right. Yeah, okay. Okay.
It will be interesting to see their brains if
Yeah,
they have a neuroprotective.
For sure, yeah. Oh, thank you, yeah, that's a great comment.
Any further questions? And I know, Bruno will. Could you turn on Bruno's?
You can just talk to the...
I think on one of your slides, there was mentioned a trial in healthy volunteers giving lithium.
Yes, yeah.
Been given lithium.
Yeah.
For what?
Just 4 weeks, I believe.
Hmm?
Just 4 weeks.
Just 4 weeks.
Yeah.
And after
You
these
saw
4 weeks,
an
you see
increase
an
in gray
increase
matter.
of the hippocampal volume?
This was cortical changes, increase in cortical thickness over 4 weeks.
They get it at let's say ordinary lithium levels, blood levels.
I'm not sure about that. I would assume so. I don't know exactly. Yeah.
Anyway, within 4 weeks,
Yep.
there was an effect on the hippocampal volume.
Yeah.
That's amazing.
Yeah.
Oh, and I think Rasmus has the last question.
Yes, thanks a lot for this fantastic presentation. Back in time, there was this discussion whether these thicknesses, cortical thicknesses, was also partly an artifact because of the water binding. Can you just comment on that? Have that been ruled out now, or what?
Yeah, I think we can. I mean, if you want to read more, we wrote a paper on that, or a rebuttal on that, summarizing all the reasons why this is unlikely to be the case. If that was explaining it, you should see this effect when you use some methods and not when you use other methods. You see it across the methods. You should see it when you use some analytical techniques as opposed to others. You see it across all analytical techniques. So to me, one thing that still could be done better or hasn't been done sufficiently is the structure-function link, is linking the changes in gray matter with some improvement in some system-level cognition or functioning or something else. That hasn't been well documented. That's the last piece that's missing to me being more. Now we're seeing it in the brain. Does that reflect something in real life? Is now the key question, I think. Yeah.
Okay. Thank you, Thomas, for a wonderful presentation.